Okay. Okay, good afternoon, everyone. We are going to start now. We are just 1 minute late, and those who are coming a bit late, just join us in a minute. So today we are coming together to talk, I would say, about a very important issue in life of people with disabilities. We are talking about healthcare. Yesterday I had a great possibility to visit Irish Permanent Mission, and during that meeting in Irish Permanent Mission they talk about statistics, and one of the points of the statistic was that people with disabilities die around 20 years earlier than people without disabilities. And of course it sounds really badly, because it sounds that if you have a disability, in average you have to die 20 years earlier just because of bad medical care. So it means it's important today to meet here in our side event, which is organized together with Italian organization, Disabled Advanced Medical Assistance, and Permanent Mission of Italy, Austria, European Disability Forum, and Inclusion International. Thank you so much for being today with us. Thank you so much for being ready to take an active part, because we are trying not just to speak from a panel, but also to ask for your active participation. I would like just to remind you that our event will be broadcasted on UN TV. We also have interpretation, so you could hear our event in English, Italian, Spanish, and we also have international sign language interpretation. We have very high-level participants and representatives of different ministries. So I would like to start by welcoming words from Italian Minister for Disabilities, Alexandra Occastelli. The floor is yours, and thank you so much.
Grazie davvero a tutti per essere qui, alla nostra moderatrice, all'inviata speciale del segretario generale dell'ONU, a Sua Eccellenza il Ministro dei Servizi Sociali dell'Australia, a Sua Eccellenza il Ministro delle Persone Disabili e Vulnerabili della Repubblica Democratica del Congo, al Commissario per la Disabilità dell'Ungheria, a tutti i gentili rappresentanti e delegati e anche ai rappresentanti del mondo delle associazioni. Grazie a tutte le persone che stanno svolgendo il lavoro di interpretariato. Grazie davvero anche all'Austria, che è il nostro co-sponsor, al dottor Konrad Svitek, e a Inclusion International per il grande lavoro di partecipazione, ma soprattutto per quello che fate ogni giorno per tutte le altre persone. E non ultimo la nostra moderatrice, la vicepresidente del European Disability Forum. Davvero grazie a tutti voi, perché per l'Italia il tema dell'accesso alle cure è particolarmente importante. Abbiamo sviluppato una rete per garantire supporto nell'accesso alle cure nei presidi ospedalieri, in particolare per le persone con disabilità intellettiva e relazionale, che spesso trovano difficoltà nell'affrontare anche piccoli esami.
To face exams at the hospitals, radiographies, or even dental hygiene. These are real problems that must be faced, not only trusting our good hearts, the good hearts of doctors and the staff that's available, but also in a reasonable way through protocols to which all can have access and must have access to. So our commitment is to improve the network, to spread more thoroughly this network, and to also compare and contrast ourselves with other countries to see how we can improve the right to access to healthcare for all. This is why we have here today Dr. Gelma, who represents let's say the network of the DAMA network, and thanks to his team and other doctors like him, he took to heart this issue, and for us it's an honor to be here together and to be able to discuss this with all of you. Thank you. Grazie per la sua introduzione e per l'opportunità di parlare insieme. Il nostro prossimo speaker viene dall'Austria, il ministro degli affari sociali. Sfortunatamente non poteva venire di persona, quindi abbiamo un videomessaggio. Arriva. Un disguido sul messaggio, un disguido. A questo punto andiamo direttamente al panel e oggi abbiamo 4 speaker distinti che condivideranno le proprie pratiche nel proprio paese, le proprie esperienze, le prospettive. E il primo a parlare sarà il professore Filippo Gelma e ci parlerà della sua esperienza in Italia, di appunto l'esperienza DAMA. Molto brevemente vorrei dire che viene dall'Università di Milano e lavora all'ospedale di San Paolo e Carlo di Milano. Dal 2000 ha partecipato nell'attuazione di diversi progetti riguardo a persone con disabilità e l'assistenza medica e fornisce l'assistenza medica a persone con disabilità gravi. Dal 2011 ha coordinato DAMA nella rete nei vari territori dell'Italia, fa parte del comitato del Centro per le persone con disabilità. Vorrei chiedervi di iniziare con la presentazione del professor Gelma, parlarci di più riguardo all'esperienza italiana. Buon pomeriggio a tutti. Vorrei ringraziare la moderatrice e il Ministro per le Disabilità, il Ministro Alessandro Locatello, per avermi dato l'opportunità di presentarvi l'esperienza DAMA in un contesto così importante. Grazie. Come saprete, la Convenzione sui diritti delle persone con disabilità sancisce il diritto di persone con disabilità a godere i più alti standard di salute e accesso alla sanità senza discriminazione. Ma le persone con disabilità hanno esigenze logistiche e di assistenza che devono essere riconosciute per costruire un'offerta di servizi che rispecchia le loro esigenze e rispettino i loro diritti in linea con la Convenzione dei diritti delle persone con disabilità. Il progetto DAMA è l'acronimo per Disabled Advanced Medical Assistance, viene utilizzato da 23 anni nell'ospedale di San Paolo a Milano per risolvere questioni semplici per persone con disabilità gravi. Abbiamo capito lì, in quel momento, che la nostra organizzazione ospedaliera poteva essere un ostacolo all'accesso di trattamenti per alcune persone. Non sapevamo prima che le persone con disabilità erano praticamente invisibili a noi prima. Non avevamo informazioni riguardo alla disabilità, a queste persone individuali, scarsa informazione riguardo a loro. Se non riconosciamo questo come problema, non riconosciamo le esigenze, non faremo niente per risolvere il problema. Nel nostro sistema sanitario, per promuovere l'efficienza, abbiamo costruito l'organizzazione dei nostri ospedali in una forma rigida, andando al di là delle esigenze dei nostri pazienti. Quindi omologando loro a uno standard nostro, chiedendo a loro di adattarsi alla nostra rigidità. Ma ci sono persone che per le loro caratteristiche hanno esigenze che non consideriamo normali per un paziente. Per esempio la presenza di un membro della famiglia, un assistente, una badante durante l'intero ricovero ospedaliero. Hanno bisogno di diversi tempi senza aspettare molto a lungo. Dargli tempo poi anche di ambientarsi nell'ambiente ospedaliere. Ci sono difficoltà, la paura dell'ospedale stesso, delle operazioni ospedaliere, l'incapacità di cooperare, l'esigenza di condurre esami, e fare, operare sedazioni, eccetera. Persone con disabilità gravi possono avere diverse esigenze, ma hanno gli stessi identici diritti delle persone neurotipici. È il nostro obbligo di adattare un sistema che rispecchi tutte le esigenze di tutte le persone. E in 23 anni di attività DAMA ha perfezionato un modello che può essere seguito con un approccio multidisciplinare tutte le varie fasi della vita del paziente, dalla diagnosi alla morte, usando quello che è già disponibile nei nostri ospedali. E il modello DAMA viene descritto in questo diagramma. L'obiettivo è quello di creare risposte flessibili, adattate alle esigenze di ciascuna persona con disabilità e le sue famiglie, dando continuità al percorso di cure, mantenendo il controllo dell'intero percorso. Il modello, la parola chiave è flessibilità, continuità, controllo. Per fare ciò abbiamo dato all'equipe di medici e infermiere che si prendono cura del paziente. Possono essere contattate facilmente da un telefono, un numero verde, si valuta il programma giusto per il paziente, si cerca di trovare un percorso più adatto ad un problema specifico per quel paziente e la sua famiglia, utilizzando tutte le capacità e servizi già disponibili nell'ospedale. Il percorso clinico usa cliniche specializzate, quelli convenzionati con DAMA, i ricoveri ospedali normali e ricoveri d'emergenza cercano di seguire il nostro modello. Cerchiamo di evitare il percorso standard, limitarli al minimo. Soltanto a delle indicazioni cliniche molto specifiche. Questo è un punto chiave del modello che riduce il tempo speso della persona con disabilità, riduce di molto e quindi pone il paziente in un ambiente più calmante, dove la persona si trova più a suo agio con risorse disponibili che le aggrada. Abbiamo creato un archivio clinico dove
already during the phone call, reporting not only the patient clinical data, but also his personal characteristics, his preferences, and how behavioral difficulties have been managed in the past. This helps to not repeat mistakes, to not repeat the same mistakes, or to replicate ways that have been successful in the past. Few minutes to show you some picture. This is DAMA call center. As you can see, it's a very congested room. All the computers are connected with our archive and our database, in which we trace the pathway organization and we mark every helpful information to perform it. DAMA is a really small ward of the San Paolo Hospital in Milan, and the planning of each day's activity is completely managed by the DAMA team. Having a dedicated DAMA rooms is important to modulate the activity according to the characteristics of our patient, to welcome them together with the family in the best way, creating an atmosphere of calm welcome. It's very important. These are our rooms. We have only 3 beds in total, in which turn about 25 patients in a day. Having dedicated DAMA rooms allow us to organize clinical maneuvers in a very personalized way, which would be impossible to realize in a room shared with other patients. As you can see by the window, the weather is rainy and cloudy, but in these rooms, it seems that the sun is shining. Just a few colors are enough to make it easier to enter a room like this. Often, to pass through a door is a big problem for our patient. But to enter this room, it does not seem to enter in hospital. This is Linda, a DAMA nurse, and Erica, who collaborate in this incredible way for the venous sampling. But you have to know that for the first time she came, Erica destroyed our infirmary. But today, Linda finds a way. She doesn't know how. And with Linda, and only with Linda, this is the way. Now you can understand that in our archive, it's surely important to know that Erica has a mutation on gene TSC2, in example, but it's fundamental to mark to avoid, if possible, to organize activities for Erica if Linda is in vacation. Remember that all the clinical data are simple to find in our hospital. What we don't know, and we need to know, is how to perform the clinical program. And if we mark how in our archive, everything become easier. Sometimes, instead of pharmacological sedation, we use sensorial distraction. In this case, Maria's sister is very able to do it, and our nurse can proceed without difficulty. Surely, we mark this fact in our archive for next time. Empathic approach is very important. You can see Christiana to visit the patient without the physician white coat, but dressing a wonderful smile that everyone should want to receive. You have known Nurse Linda. She has prepared in our day hospital Isabella for a little surgery. This is the doll of Isabella, and Linda is told to Isabella that the intervention is for her doll. And she must be brave to help her doll. In fact, also the doll is connected to the monitor, as you can see. The father of Isabella is within the outpatient operatory room until Isabella is awake. In this way, we can avoid persedation, and we can simplify the clinical pathway. At the end of procedure, obviously, Isabella and the doll have the same bandage on the left eye. Sometimes the only way to obtain collaboration is by pharmacological sedation. It isn't always simple to obtain good and safe sedation by pharmacological, good and safe obtain collaboration by pharmacological sedation, excuse me. DAMA team must be ready to manage the situation in every condition of sedation, from the light one to the deepest sedation. In this case, it's better to concentrate a lot of clinical testing sequence to reduce the risks of a long pharmacological sedation in a location that has not been designed to do this. This is an amazing picture. Our nurse Stella bet with us she was able to put to bed this little boy of 110 kilos to register an electrocardiogram. As you can see, she won the first part of the bet, but the patient regularly turns upside down. Not so easy to get a good result. Never say never. After a lot of love, without sedation, she overcame. And subsequent times, it was not necessary to use pharmacological sedation for this patient. We have learned to give everyone the right time. This corridor is overcrowded of patient, parent, caregiver. You know that 25 patients in a day means at least 50 persons and more. We have to manage in a very small place. But in this case, for Damiano, we have organized this situation. He is suspicious and needs his time to decide if and when to trust. And step by step, it's possible to gently approach, and next time it will be easier. We have learned to speak with the parents of our patients. They are an incredible source of information for us and must always be involved. This kind of communication is very difficult because they are also emotionally involved, but they are able to recognize every difference from the normal situation of their son. But we must never forget to involve also our patient. Juan Andres seems to live in another planet, but if you can get in touch with him, you can discover a shining smile that reminds you his right to participate. This slide reports the numbers of DAMA activity using this model. The numbers are very important for our small hospital unit. You can see the number of patients in charge down on the right, and the number of accesses up on the right. But the most important data I want to stress is this. All over the years, despite the numbers of patients in charge grows, the number of ordinary hospitalization and emergency accesses remain the same. This graphic, as you can see, show the orange and the blue lines quite invisible all over the years, while the number of patients in charge, the green line, regularly grows. The growth of the number of the patients in charge has created the sustainability issues and has made evident the need to export DAMA model to other hospitals. Since 15 years, we have started an important journey to present DAMA experience throughout Italy and beyond. And we managed to create other DAMAs in many hospitals. In 2019, before the start of the COVID pandemic, there were about 20 DAMAs in Italy. After the pandemic, which has brought to light many problems of access to care for people with disability, there has been an acceleration in the number of DAMA centers, with many requests for training events and for supporting the implementation of the model. The diffusion of the DAMA model has demonstrated the flexibility of the model itself and its ability to adapt to hospital with very different characteristics and dimensions. The diffusion of the model has become a necessity in order to be able to give a response to the health need of many people with disability who are unable to access the treatment pathway of our hospitals, who have the right to quality care, have the right do not have long journeys to reach hospital capable of welcoming them effectively. But the challenge for the future must go beyond this. Healthcare personnel must receive training on disability issues. A cultural change is needed, not only in healthcare personnel. We must maintain control over the DAMA model dissemination process, verifying the quality of services. It's also necessary to include local healthcare in DAMA network to give greater continuity and greater proximity to clinical pathway. And more, it is necessary to join the DAMAs in an organized network which uses common clinical protocol, which has an homogeneous archive capable of collecting epidemiological and clinical data useful for scientific research and for training of health personnel. These data are very poor and inhomogeneous today. For the reason, we are building a web platform for the DAMA network. I hope it will be fully operational in 2024. In this photo, you can see the historic first step towards the DAMA network. In 2016, all the physicians of the DAMAs met in Milan to put the first basis of the network. And to address this path, in February 2020, the physicians and nurses of the DAMAs have decided to join in an association to study this process, to define protocols and guidelines in a scientific way, involving the association or the person with disabilities to present data and possible solutions and to ensure the best responses to the health needs of people with disability. The COVID pandemic made our work difficult right from the start, but we are ready and determined to continue on our path. It's a very long road to travel, but DAMA's journey began 23 years ago in Milan, and it is incredible for me to realize that today, 23 years later, thanks to the work of the people who collaborate to this project, DAMA has become a beautiful and important reality, and I'm here to present it to you at this conference in the United Nations headquarters in New York, to keep looking forward. Thanks for your attention.
I'd like to say thank you to Professor for absolutely wonderful presentation. Do you know, sometimes we are just thinking about quality of healthcare. And of course, that is so important. Without quality, we can't reach really good results. But as we can see today from the presentation, it's not enough only to think about quality. Medical care is some kind of very human profession. And so it means we should care not only about quality, which I said is important, of course, but about small, very important things, like a course in a room where persons is coming, like attitude toward the persons, like a dress of the nurse. Maybe the white one isn't the best one when we are talking about people with very severe disabilities. Small and very important things which could make healthcare much better. And I would say Italian experience is absolutely great. And maybe we do have any other experience in other countries. So we are coming now to Austria. And I'd like to ask Konrad Svitek from Austrian Ministry of Social Affairs, Healthcare and Consumer Protection to share your national experience and the way how you are working. Thank you.
Thank you, Chair, and thank you, dear Minister. It's an honor for me to take part in this panel and in this very interesting and inspiring side event. Good afternoon to everyone. My name is Konrad Svitek. I'm from the Federal Ministry of Social Affairs in Austria, and I'm a legal expert in the Department for Disability Rights. And our unit is the CRPD focal point at federal level, and we also coordinate the National Action Plan on Disability, which is the strategy for the implementation of the CRPD in Austria. We also deal with legal issues such as the non-discrimination law with the Federal Disability Equality Act, and right now the transposition of the European Accessibility Act with the new Federal Accessibility Law. When it comes to health policy, the Austrian federal government is preparing a major health reform with the aim to modernize the health sector. However, I cannot go into detail about these health policy measures as this is the responsibility of other colleagues. But I can gladly talk about objectives and measures in the context of the new National Action Plan on Disability. As mentioned, this is the long-term strategy for the implementation of the CRPD, and it runs from the years 2022 until 2030. The action plan contains 8 major chapters and 55 sub-chapters, and it covers largely all areas of life of people with disabilities. One of the major chapters is health and rehabilitation. And before I go into the contents, I will briefly introduce the concept of the action plan. We started the process in 2019 with 26 participatory teams. We chose a bottom-up approach and asked all ministries and all regions to set up a team to deal with their topics following the principle of disability mainstreaming. And one of the teams was dealing with the topic health and rehabilitation. The team was led by the Ministry of Social Affairs with experts from the fields of health and social insurance, and representatives of people with disabilities were also involved in this process. Then all contributions of the teams were collected and edited in a participatory team in our unit at the ministry, together with representatives of the civil society, as well as the independent monitoring committee. This whole process took about 3 years, and the action plan was adopted finally in July 2022. The English translation of the action plan will be available soon at the website of our ministry, and there will be an easy-to-read version in German as well. So what does the action plan provide for in terms of health and rehabilitation? The central starting point was, of course, Article 25 of the CRPD, and the initial situation is explained in the action plan. The chapter contains 22 goals and 30 concrete measures. And just a few examples to give you an impression of the content. I would like to mention that you can find the detailed information in the action plan. As there is a lack of data and information, this will be collected. Databases about the requirements of people with disabilities will be created in the area of social insurance by 2030. Comprehensive accessibility will be or should be established in all health facilities. That's a common goal. There will be a survey by 2025 about the current status regarding accessibility of the health system with the involvement of people with disabilities and experienced experts as a starting point for creation of a staged plan in the health sector. Inclusive outpatient clinics in association with hospitals will be expanded. Their conception and realization will be concluded by 2030. Medical care should be comprehensively guaranteed for all persons, including for persons with learning disabilities, severe disabilities, and restricted communication. The action plan also acknowledges that training of persons working in the health sector is essential and necessary. There are also measures planned regarding assistive devices, such as the creation of one-stop shop possibilities and closing of funding gaps. Due to the federal system in Austria, there are still problems. In addition, in the health sector, there is a separate rehabilitation plan 2020 and a separate women's health plan, which also pays special attention to women with disabilities. When it comes to existing projects, there are also good examples. The outpatient clinic for inclusive medicine in the city of Linz, or outpatient clinics for deaf persons in several hospitals. But there are also legal requirements when it comes to new group practices or primary care units. They have to be accessible. And the plan of the government is to expand the number of primary care units in the next years. In order to inform the public about existing offers, there is special information material of the Medical Association and a special website where doctors with accessible surgeries can register voluntarily and give information about accessibility. To conclude, the development of an inclusive and accessible health system is an ongoing process in Austria, in which important developments have already happened, but a lot of work is still ahead of us. The National Action Plan on Disability is one of the instruments which will help to create a more inclusive and accessible health system, and I will definitely inform about this interesting side event or report to our health experts in our ministry who are responsible. Thank you very much.
Thank you very much, and I would say it's a very interesting experience. From one side, we have Italian experience when we talk about special clinics for special people, and now we have this Austrian experience when we are talking so much about mainstreaming. And I would say both those approaches could be very important for people with disabilities, because some of them will be very happy to be mainstreamed, but some of them, as you said already, deaf people, for example, could be much more happier to have their own community and their own possibility to have to the medical professionals and to get medical care. But you still have 7 years to go. So I have possibility in 7 years' time meet again and ask, how are you doing now? And we'll see. I hope it's going to be very great. But now we are going to the next country. We are going to the Czech Sweden. I hope I pronounce it quite good. And he's the president of Keystone Human Service International. So could you tell us a bit more about your experience in healthcare?
Hi, everyone. Thank you to our moderator and to the permanent missions of Italy and Austria for this invitation to speak with you today. My name is Chuck Sweeter, and I'm the president and CEO of Keystone Human Services. I'm a white male in his early 50s with salt and pepper hair, wearing a blue suit, a blue shirt, and a red tie. Keystone Human Services is a not-for-profit organization that was founded in the United States in 1972. Our vision is that everyone, regardless of background or ability, can be valued and contributing members of their community. We provide service in the United States for people with intellectual disabilities, with severe and persistent mental illness, and with autism. We also operate in the Republic of Moldova and in India. where our teams are not only providing certain services, but also helping to develop new inclusive programs and sustainable service systems. Today, I've been asked to talk with you about our work in the United States. Health equity is an issue that we as a provider of services for people with disability face every day. Access to health care is a human right, but in our work of supporting people to live their best lives, we experience the discrimination and barriers they face as we navigate doctor and dental appointments together. Physicians in the United States are not well prepared to work with people with disabilities. They do not have either the training or background on ways to communicate with or accommodate the needs of persons with disabilities. In addition, physicians in the United States have productivity measures that must be met for them to meet financial goals. Working inclusively with people with disabilities often requires additional time and accommodation. As a result, this either means less reimbursement or the physician working additional hours. So with healthcare professionals not being equipped to support people with disabilities and facing financial disincentives, how can we be more inclusive and remove the barriers for people with disabilities? And what can one organization like Keystone do in order to help make change in a huge system? Where do we even begin? I recently saw professor and author Alonzo Kelly speak, and he said something that resonated with me. It's the start that stops most people. And I think that's particularly true when facing an intricate global issue, such as health equity for people with disabilities. The first step in such a journey takes courage, will, and a commitment to an ongoing process. And that start is daunting and stops most people right here. Keystone operates the Adult Community Autism Program, or ACAP, in the state of Pennsylvania for 200 individuals with autism. In this unique program, Keystone is also the managed care organization responsible for the health care for these 200 individuals. When forming our healthcare provider network, our funder, the Bureau of Supports for Autism and Special Populations, responding to our advocacy, created an online 7-hour training called Spectrum, which is completed by all healthcare professionals who support people in our program. The Spectrum training contains 9 different modules on the unique needs of people with autism. In addition, Keystone uses a document called My Patient Profile, which is completed by each of the people that we support in the ACAP program and is updated regularly. The profile gives our participants a way to specify their preferences in advance of doctor's appointments and helps to inform healthcare providers about personal decisions and how to provide more inclusive services. Some of the preferences in the profile include whether the person will advocate for themselves or if a delegate will advocate for them, what might make them comfortable or uncomfortable during the visit, and how that might be expressed. Ways to communicate during the visit: repeat things, speak slowly, use hand gestures, tell me what you're going to do before you do it. And the physical environment: let the person wait in the car instead of a waiting room, dim the lights upon entry. Another important component of our support is to look within our organization and ensure that we're preparing our own staff well to be allies and advocates. Keystone is a member organization of Inclusion International, and you'll hear more about the Listen, Include, Respect global guidelines from my fellow panelist, Dominique. We're pleased to be working in partnership with Inclusion International to leverage these guidelines internally for our organization. These guidelines reiterate much of what we already do every day, but importantly, they reinforce strongly that people with disability are the experts in their own lives. The guidance also gives us additional tools to work with community partners like medical professionals in a way that improves inclusive approaches. In addition to the health equity measures we apply in the ACAP program and adopting the Listen, Include, Respect guidelines, we have also initiated conversations with the Department of Human Services in Pennsylvania. We are fortunate to have an advocate named Dr. Jennifer Chambers, who is a 20-year Keystone board member, a physician, a former health insurance executive, and the parent of a son with a disability, as our guide. Her unique perspective across the disability and healthcare arenas has been invaluable to us and helps guide our strategy moving forward. Our current goal is to create a task force to address the issues of healthcare access and equity, followed by several small pilot projects. The task force will and must include all stakeholders: people with disabilities, advocates, physicians, family members, insurance companies, government officials, direct support professionals, health systems, and funders. There are so many aspects to be discussed, key among them being, what are the outcomes that we want to achieve? CMS recently released their Framework for Health Equity, and Priority 5 is increasing all forms of accessibility to healthcare services and coverage, which includes direct feedback from people with disabilities. What incentives can we provide to physicians for the additional time and understanding required to fully and more inclusively serve people with disabilities? And how is individual choice with decision-making supported well? And how do we shift mindsets around the perceived capacity of people with intellectual and developmental disabilities? The collective impact approach of this task force is absolutely critical if we are to make a true change. It will depend upon the commitment and collaboration of a diverse group of actors who work together on this common agenda and in a sustained way. The Sustainable Development Goals and our global health priorities will not progress otherwise. At Keystone, we will continue to do our best to provide support for people to be included, listened to, and respected. We are proud to be a part of this global advocacy movement. Ensuring the accessibility and inclusion in health services and the highest attainable standard of health for people with disability is a priority, and the time is now. Thank you very much.
Thank you very much, Mr. Sweeder, and I have a feeling that you have some kind of system into a system. So you have a special kind of system for people with autism, which looks really great. Last year, I get a call from a guy from Moldova, and he said, "Hi, I'm from Keystone." And I said, "Oh, I don't know such kind of organization." And he said, "How do you know? We are the biggest in Moldova and the best. And we are in New York too." And now, not now, but then, he explained me everything about it. And he explained how good you are. And then we started to cooperate with him and Keystone in Moldova. And so coming to US now, it was very great to see how many you are doing here and how much you are also doing in Moldova. And it really sounds great. So, but you said already that you are going to follow some kind of guidelines. And now we are going to talk more about those guidelines. We have a representative from the Executive Director of Inclusion International, Connie Lauren Bovey, if I understand right. So could you tell us a bit more about guidelines we mentioned already?
Buenas tardes, mi nombre es Dominicana.
Good afternoon. My name is Dominique Cantor and I'm Argentine. I appreciate the opportunity and the honor of being at this event. When some people think about health, people like me who have intellectual disabilities many times only think about the medical issues. However, we all know that disability is much more than a medical issue. For example, COVID-19 brought out the worst and the best in people. All difficult situations were made worse by COVID. I was able to see this with the American group of Inclusion International. We made a report on how COVID affected people with disabilities and their families. Everybody saw that COVID affected us in our countries. Most people that were surveyed told us that for the 2 years, there wasn't enough information that was easy to understand, because people that have intellectual disabilities have full capacity otherwise. But people keep making decisions about our bodies and about our lives, for worse, of course. Disabled women can become victims of more abuses, which are difficult to recognize. People with intellectual disabilities need more support than other people, and it's true, because everyone has the same right to decide about our own lives and about the support and care that we need. We simply need more time to think, to decide, to think, to decide. We need information with easy to understand information about health issues. For example, on sexual and reproductive rights, we have to have informed concern in easy reading, understanding the drug indications, because it's usually very difficult to read and understand these. It is also very important to understand that our health doesn't only depend on our bodies. Health is also about the society in which we live. That is why the people who work for our health must know and understand what happens to us with education and work. For example, some mental health institutions, we need to be able to come out and be able to live independently. But in order to do that, we need easy to understand information. So I have to ask, how can we live by ourselves if we don't have easy to understand information? So that we can be, so we can take what kind of support and make our own decisions. Organizations that work for our health need to be inclusive, and they need to listen to us, because many times what happens is that organizations want to be including, but they don't know how to. And that is why, along with Down Syndrome International, we made a Listen, Include, and Respect guide. This guide brings a list of things that organizations can do to be more inclusive for all people who have intellectual disabilities. We provide examples of how this can be done step by step by using easy to understand communication. To make this guide, there were 1,500 participants in 100 countries. We did a survey in 10 languages. We had one online with easy-to-read versions, of course. There were more than 60 consultations, meetings with self-advocates, with families, and with support people. Of course, all of it was in easy reading. In the Listen, Include, and Respect guide, we put the best examples of success in inclusion and easy-to-understand communications. For example, the guideline includes recommendations of all of us who participated, because many times many recommendations have to do with easy-to-understand communications. You do not need to learn the guide by heart. You don't need to have read it from beginning to end. You just have to use whatever you need from it. You may find how to organize focus groups, how to organize routines, how to prepare materials, because that's not easy for someone with intellectual disabilities to do. I invite you, and I'm very honored to do so because I was participating in this guide, to take advantage of this guide to Listen, Include, and Respect. It's great to share, and it's great to use. And we did this so we could share it with you, so we could continue working with you, with us, not for us, but with us, because together we can make this much more inclusive. We could make a better world in which the right to health is a right that is respected for everyone, for people with disabilities and without disabilities. Thank you.
Thank you, Dominika, and thank you for absolutely wonderful presentation. And I'm sorry that I haven't your name on my list, but you are great. And we will see how we can see how easy it is to provide information if you can use easy language. Sometimes when you get some letter from tax agency, you really need easy language to understand what they are writing you. Should you pay more taxes or less? So easy language is great, but especially in a healthcare, because that are issues you should understand exactly. Now we still have about 15 minutes for a very small and short introduction. As I said already, we have a high-level meeting. So we have Laszlo Lovasi from Hungary, from Ministerial Commissioner of Strategic Government Research Office in Hungary. So would you like to say some comments on our discussion?
Thank you. First of all, thank you for your kind invitation to this very important meeting. And as ex-CRPD expert for 8 years under the wonderful chairmanship of Maria Soledad, and I was honored to work with her as well. And I think my contribution would be based on my personal experience and my research and studies. Because if I recall correctly, Italy has a very long tradition in providing extended medical assistance for its citizens. And if I remember well, Italy is the country in the European Union which has a special reference to this topic even in its constitution. And I think it's very relevant to today's discussion. And apart from this, I think I recall also that Italy was among the first EU member states in launching the WHO's ICF, the International Classification on Functionality and Disability and Health, which was the first WHO classification document on disability with a holistic approach in terms of medical, social, and environmental experts. So I think Italy can be considered as a forerunner in this regard. And in relation to this, we know that Italy has a very good numbers and figures in terms of life longevity, and years expected in good health also excels Italy in this regard, and that's why I think it's a very good topic and opportunity to talk about the project DAMA, as we saw during excellent presentations. And Italy also and Austria as well also are very important countries when it comes to the handling of aging society. Also important aspect in today's challenges in the EU. And DAMA project is, if I understood well, is about access to big data, the further application of artificial intelligence, or even inputs for other scientific breakthroughs in the long run. And it means that we have several issues, areas which will be more important in the near future. And I think these aspects can be divided into two main topics. One topic is about, let's say, a precondition to DAMA project. The other topic is about DAMA project itself. When it comes to precondition to DAMA, I think it is about access to data, access to early recognition, access to up-to-date research, and access to guidance on prevention and rehabilitation. And all these aspects lead to the second topic, which is about the DAMA project on simplifying the procedures in health system, as well as more efficient units and professionals, leading to generating a kind of safeguard in transparency. I think transparency is the most important thing in relation to the application of the convention, because it's about convention is about ensuring the rights of persons with disabilities, and transparency is serving this purpose, which means that when talking about follow-up of DAMA project, I think we also should talk about mitigating the consequences of the therapies, the consequences of treatment, as well as strengthening the possible prevention-related aspects, leading to more transparent procedures in ensuring rights of persons with disabilities. So, to sum up, I would like to congratulate you on this project, and I think it is worth considering it as a good example for further consultations and experience. Thank you for inviting me to this session.
Also, thank you so much. The key word is transparency. Transparency is quite important in healthcare, of course. I know that we have somewhere the Minister of Social Services from Australia. So maybe you'll be happy, Amanda Richworth, to say a few words from Australian perspective. She left already? Okay, sorry. And then we also have a Minister for Persons with Disabilities of Democratic Republic of Congo, Irena Esamba. So Irena, maybe just few reflections on what you have heard today. No, maybe someone could help us by translation. We don't have a French translation.
Vuole farlo può lui.
Yeah, thank you so much. Thank you so much.
Merci beaucoup pour la parole.
une personne comme les autres personnes dans la société et il faut la considérer avec ses droits et ses obligations et tenir compte de ses besoins, lui faire parler et éviter que les autres parlent à sa place. Et pour ça, même les services à mettre en place pour lui, il faut qu'elle soit impliquée dans la recherche ou dans l'adaptation de tout ce que nous sommes en train de faire. Dans le cadre de mon expérience, nous sommes en train de mettre en place des programmes pour l'inclusion sociale, l'inclusion économique et aussi la participation dans les institutions concernant les personnes handicapées. Et tous les programmes et politiques que je suis en train d'élaborer, je le fais avec le groupe d'experts, mais au finish, je le fais valider par les personnes handicapées pour qu'elles se reconnaissent dans tous ces programmes parce que c'est une nouveauté dans notre pays. C'est le président Félix-Antoine Tshisekedi. Lorsqu'il est arrivé, il a mis une attention particulière sur la personne avec handicap et il a créé pour la toute première fois le ministère que je dirige. Et comme ça, il faut que les personnes avec handicap soient impliquées et aussi la communauté doit connaître ce que nous sommes en train de faire. Il y a beaucoup de défis parce que dans le domaine du handicap, nous n'avons pas beaucoup de moyens. Nous avons besoin des ressources, pas seulement des ressources financières, mais nous avons aussi besoin de ressources techniques, des ressources en termes d'équipement. Et c'est pour cela que j'ai préféré participer à cet événement parce que je voudrais écouter ce que les autres font et comme ça, ça va nous inspirer pour aller de l'avant. Je crois que c'est à ce niveau, mais je veux mettre un accent particulier sur le fait que les personnes avec handicap sont de plusieurs catégories. Et étant de plusieurs catégories, par exemple, pour le moment concernant les personnes sourdes, nous sommes en train d'élaborer les dictionnaires de la langue des signes pour faciliter leur éducation. Nous sommes en train de travailler sur la modernisation de l'écriture braille pour aussi l'implication des enfants aveugles dans les études et surtout à tous les niveaux, même au niveau des universités. Et nous avons beaucoup de programmes par rapport à chaque catégorie de handicap. L'essentiel pour moi, c'est d'avoir une collaboration avec les autres pays et c'est pour cela que j'ai tenu à être ici. Merci.
Thank you very much. I'm pleased to be here. It's an important opportunity to share our experience in the Democratic Republic of the Congo, where we are focusing on inclusion in the framework of what I call a global approach. A person with disabilities is one person within the society. We have to listen to their needs. We have to involve them in research and adaptation. We have plans on social and economic inclusion we are working on, and I care very much that all programs and policies are validated finally by persons with disabilities. Our president has special attention on persons with disabilities and on the work of my ministry. And what I would like to stress is that the community needs to know what we are doing. We don't have huge financial resources, and we also need technical services, and we need to strengthen our capacities. This is also why I'm here. I also would like to stress that there are different categories of people with disabilities, and for hearing impaired, we are working on a dictionary for the sign language, and we also work on expanding the availability of Braille. But most of all, I'm here to learn and understand and share best practices from everyone else. Thank you very much.
Okay, thank you very much for your experience, and thank you for wonderful interpretation. Just perfect. Okay, we still have 5 minutes to go, and we have a special envoy of the UN Secretary General on Disability and Accessibility, Maria Reis. So maybe you can say some conclusion or what you are going to take with you.
Sí. Bien, ¿se escucha? ¿Sí?
Very well. Are you able to hear me? Yes? Is it on? All right. Very good afternoon to all of you. Thank you very much to Minister Locatelli for having invited me to this side event, which has left me, I would say, charmed. First of all, I would like to thank Dominique, especially from Inclusion International, because by what she has said, and she does hard work with Down International, it's really true, working with them and not just for them. I think it's been notable the way she was able to express it. And in this sense, I connect with Kingston's experience, which is taking what Down International is doing in order to implement the care programs for those on the autism spectrum. Nowadays, it is a very relevant subject, and it's very important. I would also like to give a nod to Austria, which has mentioned the programs it's going to implement. And with regard to Austria, I'd like to say that I am deeply inspired by all of the work they're doing with people with disabilities, but especially with the elderly. We know that there is an intersection between disabilities and the elderly, and that is something that we must not forget, because that's a sector of the population that's going to grow more and more over time. I've left my final words to my colleague next to me here, because the fact of the matter is, when I listened to him, it really got to me. I was moved because it's not so easy hearing from a doctor talking about models and human rights, and to see a physician who speaks as deeply as he did, emphasizing the rights of persons with disabilities. The fact is, it makes you think, this is worth living. He has spoken to us about a DAMA application that implies flexibility and control. And that flexibility and control, that is the compendium of a thorough, integrated medical care. When he tells us about all the details that they consider to care well for a patient, even the colors of the room, about whether the physician can treat them without their white garb, how this girl can be treated alongside her doll, doing everything necessary so that she can feel accepted. I think that that's a key point in humanizing medicine. That's applying human rights much beyond what the convention itself can say through words. The doctor has shown us how, through the DAMA program, and I'm really excited about it, how they truly apply human rights, but they apply them concretely in the training of their staff, how seriously they take it, how they apply control. I was studying up on DAMA and all about the medical care that's provided, and this is advanced medical care that allows for a detail-oriented care for the patient, monitoring the provision of their medications, and so on and so forth. And I say it from the bottom of my heart. I believe that what's been shared with us at this side event today. Honestly, there are very few times when I've been able to see something as clearly as what's been told to us here, as what the doctor has shared with us. And this gives me hope for us to consider doing work on healthcare access from the perspective that he shared with us. Thank you very much.
Thank you to all our panelists. And I would like to say that we have a lot of very nice examples. But those nice examples are like a small Iceland somewhere. So our next steps will be make those islands much bigger and bigger and bigger, so they can be a part of the system, and then it's going to be a system of healthcare which is accessible for people with disability and which is friendly for people with disabilities. Thank you so much.